So what would we use this for? We started out in a triple negative breast cancer model, but that's an industry standard. We are now doing our melanoma models. If you look at where's the likely place for us to find a purpose in the clinics, it's the kind of patient I just showed you. There's a lot of stuff happening in breast cancer. There's a lot of work happening in immunotherapy in breast cancer. So that's on the runway. But what's an immediate need for are these patients. These are the advanced stage 3 with this in-transit disease, or the patients with stage 4, meaning they've got disease throughout their body, but also involving the skin. That's what M1 is. And they've failed immunotherapy, they've failed surgery, or they've had toxicity to one or the other, or surgery is just prohibitive. And so in those, or they've had a partial response. We see this. Some tumors respond to immunotherapy, some don't. We can try to invigorate, to generate new immunity using this process. So that's our target audience. And so the next slide.
Carmen, I'm just going to ask you this. So we're focusing on, and this is a bit of a pivot for us, as we've talked about colorectal cancer in the past, but we think for a number of reasons that melanoma is the place to go first, and we'll talk about that later. But this is later stage 3 and 4. Why not earlier stages?
Well, because that's a very good question, because in medicine, there's just tradition is we start with the worst and we move back to the best. There are lots of options in the earlier stages, cut it out. And if you can cut it out, that's what you're going to do first. So it's going to have to be the late stage that's come back. And so stage 3 means it's in the nodes, in the lymph nodes. Now, you can give me an argument where the nodes are too bulky and I can't operate on them. I'd say that's a place to do this too. But it's going to be something that we're going to have to prove the efficacy and the safety in a patient where there was truly no other option, so that we can justify learning what we don't know, if you know what I mean. So the intended use is for these people. What we want to do is create the hyperthermia. We want to show that we can create new immunity in things that we can see, but we can't resect either because the surgery is more morbid or the extent of the disease is beyond resection without some untolerable toxicity.
Right, want to move on?
Yeah. So this is the algorithm. When a patient comes to clinic, we follow this algorithm of care. If they're resectable, we resect. If we can give a local therapy or a systemic therapy, we give it. If we have to dissect nodes, we dissect. If it's unresectable or it's recurred time and time again, then we're left with, what do we do? So this often if it happens in a leg or an arm, we can do an isolated limb perfusion. If it happens in something, we can inject. IL-2 is what I use. Imiquimod I use in Canada. TVEC is the United States, kind of like an IL-2 thing. And then we're down to some kind of systemic treatment. And the systemic treatments, if they work, that's great. They often fail in the skin. So if they fail, we have to come to what's next. So then we go to the guidelines, and we use the NCCN, the National Cancer Collaborative Comprehensive Cancer Network guidelines. And if you look in this guideline, it says workup. So we've done the workup, and now we are at the stage where we've got that area in the square to the left with the circle around it. Now, we've biopsied it, it's melanoma, we've tried everything, it's still there. Now we go to the middle column, which is your initial treatment. And that middle column is very extensive. What it means is there isn't a number one choice. It's use what you have available for you in your system to the best of your ability. That column is begging for a solution. That column should be the line A, choice B, but it's not. It is all of those things are completely acceptable because there's nothing that actually works very well.
So it'd be fair to say these are the alternatives to what we're proposing.
Yeah, that's exactly right. And that long list tells you none of them work very well individually. Right. What we're proposing is something that should put this to the top of that list.